I'm going to show images of hemorrhagic stroke with an emphasis on hypertensive hemorrhage. About 1/5 to 1/4 of all strokes is hemorrhagic, and the preferred imaging modality in stroke is CT because it is fast and easily accessible. Spontaneous intracranial hemorrhage can be divided into lobar and deep hemorrhage. Deep hemorrhage at the level of the basal ganglia and thalami is caused by rupture of one of the lenticulostriatal arteries, and the most common cause in elderly patients is hypertension. If you have a young patient, for example in his 20s or 30s, with a deep spontaneous hemorrhage, you should rule out substance abuse such as cocaine. Spontaneous hemorrhage in the brainstem, especially the pons or in the cerebellum, is also typically caused by hypertension. And lobar hemorrhage is more often caused by cerebral amyloid angiopathy that we discussed before. The second most common cause is hypertension again, because hypertension is so common, but you should also rule out other causes. On the CT in the acute phase, you can sometimes see a swirl sign or a black hole sign, which is caused by extravasation of unclotted blood into the hematoma. And this means that there is active bleeding, so faster hematoma expansion, and it has a worse prognosis. In lobar hemorrhage, you should also do a CT angiography and CT venography. On the CTA, you can look for a spot sign, which is comparable to the black hole sign, which means that there's active extravasation, active bleeding, and faster hematoma expansion. And you can also look for arteriovenous malformations on the CTA as an underlying cause for the hematoma. In the venous phase, you can look for or exclude venous sinus thrombosis and hemorrhagic transformation of a venous infarction. And you can also look for the spot sign in the venous phase. This is an example of a 97-year-old female presenting with left-sided weakness and aphasia, with a very large hematoma in her right frontal lobe. And because of the mass effect on the left frontal lobe, she presented with aphasia. You can see on the arterial phase that there is a spot sign, so active bleeding, and even more contrast extravasation in the venous phase. So this is prognostically not good. The first hours, the edema is mainly caused by cytotoxic edema, by neuronal and glial mechanisms, but after a few days, because of the disrupted blood-brain barrier, it's mainly vasogenic edema. This is a very nice example of the follow-up of a hematoma. 4 hours after presentation, where the edema has been colored green. And you can see that after 14 hours, there's expansion of the hematoma with intraventricular extension, hydrocephalus, more edema developing after 73 hours, and after 7 days there's resorption. The ruptured blood vessel is caused by the high blood pressure, and the lenticulostriatal arteries typically rupture at or near the bifurcation. And there's also some intrinsically wrong with the vessel wall, such as fibrinoid necrosis and the degeneration of smooth muscle cells. And there are also sometimes Charcot-Bouchard aneurysms, which are located at the lenticulostriatal vessels, that are the cause of the intracranial hemorrhage. They are said to be very rare, but I do not know if they are really rare or that we do not detect them at this moment. So maybe with the introduction of photon count CT in the clinical practice, we will see more of these aneurysms in the coming years. Who knows? It would be nice if you could predict the chance of rupture or hemorrhage. And there are studies looking at the morphology and biomechanics of the vessels, but that is something for the very far future. It would also be good if you can give some prediction of the outcome after hemorrhage, and that's more for the current practice. And lobar hemorrhages are typically larger than the deep hemorrhages, and they have faster hematoma expansion. So you would say that they have a worse functional outcome, but if you correct for the prognostic factors, after 19 days, in fact, the deep intracranial hemorrhages have a worse outcome. And the deep intracranial hemorrhages are very difficult to distinguish from a clinical point of view from ischemic stroke in the territory of the middle cerebral artery, and we will discuss that next time.